Chronic kidney disease, or CKD, describes a decrease in kidney function with an estimated glomerular filtration rate, or eGFR, below 60 milliliters per minute per 1.73 square meters. That happens over a minimum of 3 months, regardless of the cause. Now, if there's already kidney damage, like with glomerular disease, tubulointerstitial disease, vascular disease, or congenital renal disease, but the eGFR is above 60 milliliters per minute per 1.73 square meters, then this is still CKD, because all these conditions progressively affect the renal function, and, over time, without treatment, eGFR decreases. Now, the causes of CKD can be split into 3 categories: pre-renal, intrarenal, and post-renal causes. Pre-renal CKD causes are due to a decrease in renal perfusion, like in heart failure and cirrhosis. Intrarenal CKD causes can be further classified into renal vascular disease, glomerular disease, and tubulointerstitial disease. Renal vascular disease includes hypertension and renal artery stenosis. Glomerular diseases include nephritic and nephrotic diseases. And tubulointerstitial disease includes polycystic kidney disease. Other causes of intrarenal CKD are nephrotoxic substances like lead and certain medications like cisplatin. Finally, there's post-renal CKD, which is most commonly caused by prostate disease. Also, repeated episodes of pyelonephritis can lead to CKD. Diagnosing CKD usually requires having past measurements of the eGFR, albuminuria or proteinuria, and past urine dipstick and sediment examinations. If that isn't possible, the individual needs to have multiple assessments over a period of 3 months to confirm that the problem is chronic. That means getting serum creatinine to calculate the eGFR, along with urinalysis, both by dipstick and microscopy, to identify any abnormalities in the urine, such as hematuria, and checking the urine albumin levels. Additionally, an abdominal ultrasound is done because CKD can cause scarring, which makes the kidneys small and echogenic. However, it depends on the cause, since some causes of CKD, like diabetic nephropathy, leave the kidneys normal-sized. Now, based on the eGFR, CKD is classified into 5 stages, called G stages, measured in units of milliliters per minute per 1.73 square meters. G1 is when the eGFR is above 90, but there's an underlying kidney disease. G2 is when the eGFR is between 60 and 89, and this is considered mildly decreased kidney function. G3A is when the eGFR is between 45 and 59, and this is mildly to moderately decreased kidney function. G3B is when the eGFR is between 30 and 44, and this is moderately to severely decreased kidney function. G4 is when the eGFR is between 15 and 29, and this is considered severely decreased kidney function. Finally, there's G5, where the eGFR is below 15, and this is end-stage renal disease, or ESRD. For individuals with stage G5 CKD, if they're also on dialysis, a D is added to the G stage, so it's called G5D. Now, albuminuria, or the albumin excretion rate, has also been added to the CKD staging, and they're called the A stages. A1 is when the albumin excretion rate is less than 30 milligrams per day, and this is normal to mildly increased albuminuria. A2 is when the albumin excretion rate is between 30 and 300 milligrams per day, and this is moderately increased albuminuria. Finally, there's A3, where the albumin excretion rate is over 300 milligrams per day, and this is severely increased albuminuria. We use both these staging systems because the higher the stage, the higher risk of mortality and progression of CKD is. Individuals with CKD can develop signs and symptoms due to their decreased renal function, such as edema and oliguria, meaning a urine output less than 400 milliliters per day, fatigue, weakness, and anorexia. Individuals with CKD may also have hypertension from sodium retention, increased activity of the renin-angiotensin-aldosterone system, and secondary hyperparathyroidism. Additionally, the individual may have symptoms from the underlying disease, such as gross hematuria, with IgA nephropathy or shortness of breath from heart failure. CKD can also cause complications like anemia, which might be due to the kidneys making insufficient erythropoietin. In individuals that undergo hemodialysis, anemia can be caused by regular blood loss during hemodialysis sessions. Individuals with CKD are also prone to iron deficiency anemia for several reasons. Some have diet low in iron, blood loss during hemodialysis, or impaired absorption of iron. Another complication of CKD is mineral and bone disorder, sometimes called CKD-MBD for short. CKD-MBD includes metabolic changes that result in hyperphosphatemia and hypocalcemia, skeletal abnormalities like bone fractures, and extraskeletal calcifications like coronary artery calcifications. CKD-MBD develops for a number of reasons. First, the kidneys can't excrete phosphate, leading to hyperphosphatemia and improper conversion of 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D, or calcitriol, which is the active form of vitamin D. Low levels of calcitriol leads to hypocalcemia. Hyperphosphatemia and hypocalcemia lead to increased levels of parathyroid hormone, which is a type of secondary hyperparathyroidism, and the parathyroids become bigger. Sometimes, PTH can be the first one to increase due to increased PTH gene expression, so phosphate and calcium levels can remain normal for a long period of time. Now, after a long period of time with secondary hyperparathyroidism, the large hypertrophied parathyroids start secreting even more PTH, regardless of triggers like hyperphosphatemia, hypocalcemia, or vitamin D deficiency. This is called tertiary hyperparathyroidism. In this case, really high levels of PTH can lead to hypercalcemia. Another complication is hyperkalemia, which can cause symptoms like palpitations, paresthesias, and muscle weakness. Finally, CKD can lead to metabolic acidosis, which can lead to dyspnea, or if it's chronic, may be asymptomatic. Now, in individuals with ESRD, there may be uremia, which is caused by the accumulation of uremic toxins, including urea itself. Symptoms include nausea, vomiting, weight loss, fatigue, and pruritus. Another sign of uremia is bleeding and easy bruising, and that's due to platelet dysfunction. There's also uremic pericarditis, which can cause chest pain, and on auscultation, there's a pericardial friction rub. Next, there's uremic neuropathy, affecting the central and peripheral nervous system. Clinically, there's progressive encephalopathy that causes confusion, asterixis, and myoclonus. It can also cause distal symmetrical polyneuropathy and paresthesias. Finally, in severe cases, it can cause seizures and coma. There can also be sexual dysfunction that presents with decreased libido and erectile dysfunction in males and amenorrhea in females. Further lab work consists of blood serum glucose, and hemoglobin A1C levels are checked in individuals with diabetes mellitus. Individuals with CKD are at a higher risk for cardiovascular disease, so cholesterol, triglycerides, LDL, and HDL levels are also checked. The most common finding in CKD is high triglyceride levels. Electrolyte levels and an ABG are done to assess for metabolic acidosis. Additionally, with ESRD, albumin levels are also checked, and they're usually low when there's malnutrition. If the individual's at stage G3, then a CBC is checked because CKD can cause a normocytic and normochromic anemia. Additionally, serum iron, TIBC, and ferritin levels are also checked to assess for iron deficiency. In iron deficiency, serum iron is low, TIBC is high, and ferritin is low. Now, to evaluate CKD-MBD, phosphate, calcium, PTH, and vitamin D levels are checked. Once the individual is at stage G3, PTH levels usually increase and vitamin D levels decrease. Calcium and phosphate levels can remain normal for a long time, typically until the individual reaches stage G4, where there will be hyperphosphatemia and hypocalcemia. This happens because high PTH gene expression leads to high PTH levels, which in turn increases phosphate excretion. An abdominal ultrasound is usually done to check the size of the kidneys and to look for evidence of hydronephrosis, which can cause obstruction. When PTH levels are high, a parathyroid ultrasound can be done to see if the parathyroid glands are larger. Treatment of CKD starts with stopping any nephrotoxic medications, like NSAIDs and aminoglycosides, and making sure the cause isn't pre-renal, in which case IV saline can be given to restore the intravascular volume. After that, the goal is to slow the progression of renal disease, rather than stopping it. First, dietary recommendations include keeping the caloric intake between 30 and 35 kilocalories per kilogram per day to help manage body weight, since a high BMI is a risk factor for worsening renal function. That works out to just about 2,300 kcals per day for a 70 kilogram adult. Now, if the individual is not on dialysis, then protein restriction is recommended, 0.8 grams per kilogram per day. If the individual has hypertension or volume overload or proteinuria, then sodium restriction is set at about 2 grams of sodium per day, which is roughly 1/3 of a tablespoon of salt daily. Additionally, with volume overload, an oral loop diuretic, like furosemide, is used. If hypertension or volume overload or proteinuria aren't present, then 2.3 grams of sodium per day can be consumed. Next, calcium intake should be below 1 gram per day to prevent tissue deposition. Potassium intake is based on potassium levels, but generally speaking, when the eGFR is below 30 milliliters per minute per 1.73 square meters, potassium intake is limited to a maximum amount of 4 grams per day. General measures include smoking cessation in all individuals with CKD, and having tight glycemic control among individuals with diabetes mellitus. Now, two factors that accelerate the progression of CKD are hypertension and proteinuria. If there's only proteinuria, meaning more than 1,000 milligrams of protein lost per day, then treatment with either an oral ACE inhibitor, like enalapril, or an oral ARB, like losartan, is initiated. Now, if there's only arterial hypertension, then an ACE inhibitor or an ARB is started. The goal is to get the systolic blood pressure below 130 millimeters of mercury, but not below 110 millimeters of mercury, and the diastolic blood pressure below 80 millimeters of mercury. Now, if there's both hypertension and edema, then an oral diuretic like furosemide is given as a first choice. Another risk factor is hyperlipidemia. Now, when individuals are at stage G3, they should be started on a statin, like atorvastatin, to reduce the risk of cardiovascular disease. If LDL levels are high, statin therapy is recommended until the level is below 70 milligrams per deciliter. If there's hypertriglyceridemia, which is when triglycerides are above 200 milligrams per deciliter, then weight loss and exercise are recommended. Next, there's treatment and prevention of complications, which begin to appear in individuals at stage G3. In individuals with chronic metabolic acidosis, like alkali therapy is used to keep the serum bicarbonate between 23 to 27 milliequivalents per liter. Between 0.5 and 1 milliequivalents per kilogram per day of oral sodium bicarbonate or oral sodium citrate is given daily. Treatment of anemia depends on the cause. If there's also iron deficiency, then oral iron supplements are given, which can be taken with orange juice, which is slightly acidic and can help absorption. If oral iron isn't effective, or the side effects can't be tolerated, IV iron can be used instead. Now, if hemoglobin levels are below 10 grams per deciliter, and it's not due to iron deficiency, then treatment using subcutaneous erythropoiesis-stimulating agents, like epoetin or darbepoetin, is started. Treatment of CKD, MBD, starts with treating hyperphosphatemia if it's present. First, dietary phosphorus intake is restricted to 900 milligrams per day. If dietary measures don't lower phosphate levels, then non-calcium-containing phosphate binders, like oral sevelamer, are used. Hypocalcemia isn't always treated because vitamin D supplementation can lead to hypercalcemia, which can then lead to extraskeletal calcifications. However, if PTH levels are above 195 picograms per milliliter, and there's vitamin D deficiency and hypocalcemia, then oral calcitriol or alpha-calcidol is given. In individuals at stage G5, meaning ESRD, renal replacement therapy is recommended, and this also helps prevent or treat uremia. Generally, individuals at stage G4 are informed about renal replacement therapy options, which include hemodialysis, peritoneal dialysis, and renal transplantation. Typically, these options are initiated when there's any evidence of uremia. Other indications for renal replacement therapy are volume overload refractory to diuretics, hypertension refractory to antihypertensive medications, persistent metabolic disturbances like metabolic acidosis, hyperkalemia, hyperphosphatemia, hypo or hypercalcemia that are refractory to medication, or refractory symptoms like nausea and vomiting. Generally, a kidney transplant is the best option for renal replacement, but it's not always possible. Absolute contraindications for a kidney transplant are active infections like hepatitis B, malignancies like pancreatic cancer, active substance abuse, uncontrolled mental illness, treatment non-adherence, or any other risk for a shortened life expectancy. In these cases, hemodialysis or peritoneal dialysis can be tried instead. In hemodialysis, there are three major types of vascular access that can be used. First, there's an AV fistula, which is when an artery and a vein are surgically ligated in the arm and then strengthens over 6 months into a strong blood vessel. Typically, a person is referred for an AV fistula surgery when they're at stage G4 and when creatinine levels are above 4 milligrams per deciliter, or when there's a rapid decrease in renal function. The arm with an AV fistula shouldn't be used for blood drawing or for blood pressure checks, and the individual shouldn't sleep on that arm or carry anything over 5 pounds with that arm. And that's because this can cause bleeding or an infection, which can damage the AV fistula, making it unusable for hemodialysis. If an AV fistula can't be surgically formed, then an AV graft made from polytetrafluoroethylene is placed between an artery and a vein from the arm. This can be done just 6 weeks prior to the initiation of hemodialysis. An AV graft isn't always used because there's a higher risk for thrombosis or infection. In situations where hemodialysis needs to be initiated before 6 months, tunneled hemodialysis catheters can sometimes be temporarily placed. These are usually placed in the right jugular vein, and the catheter is tunneled under the skin. This is usually done when an individual needs hemodialysis, and the AV fistula hasn't matured yet, or when an individual is a poor candidate for an AV fistula, like individuals with congestive heart failure. These aren't usually used because they can cause immediate complications like bleeding or pneumothorax, or long-term complications like thrombosis or central vein stenosis. Finally, there's peritoneal dialysis, which is when a peritoneal dialysis catheter is surgically placed in the abdominal cavity and a dialysis solution flows through the catheter and into the peritoneal cavity. The fluid dwells in that space, and toxins and excess water diffuse across the peritoneal membrane. Generally, after a few hours, the fluid from the peritoneal space is drained through the catheter and another dialysis solution is introduced into the peritoneal space. Alright, as a quick recap, CKD has 5 stages based on the eGFR, albuminuria, and kidney damage, which includes pre-existing conditions like glomerular disease, tubulointerstitial disease, vascular disease, or congenital renal disorders. The higher the stage, the most likely progression of the renal disease is. The individual may have edema, oliguria, and hypertension. For individuals at stage G3, complications can develop like anemia, CKD-MBD, which includes hyperphosphatemia, hypocalcemia, high PTH and vitamin D deficiency, hyperkalemia, and metabolic acidosis. With ESRD, there's typically uremia, which can cause uremic pericarditis, uremic bleeding, and uremic neuropathy. Lab work includes serum creatinine, BUN, urine analysis, albuminuria test, blood serum glucose, HbA1c, cholesterol, triglycerides, LDL and HDL levels, electrolytes, and an ABG. With ESRD, albumin levels should also be checked. A CBC is done to check for anemia, and HB levels are under 12 grams per deciliter if present. If there's also iron deficiency, TIBC is high and ferritin is low. For CKD-MBD, serum phosphate, serum calcium, along with PTH and vitamin D levels are done. In CKD, an abdominal ultrasound usually shows small kidneys. The goal of treatment is to slow the progression of disease. This can be done through dietary modifications, controlling hypertension, the goal being less than 130 over 80 millimeters of mercury, and controlling proteinuria to less than 1,000 milligrams per day with ACE inhibitors or ARBs. If there's hypertension and edema, then a loop diuretic is the first choice. Individuals at stage G3 receive statins to reduce LDL levels to below 70 milligrams per deciliter. If there's hypertriglyceridemia, then lifestyle changes are recommended. Treatment of volume overload is done with sodium restriction and an oral loop diuretic. Hyperkalemia can be prevented through diet and avoiding medications that increase serum potassium. Chronic metabolic acidosis is treated with oral alkali therapy. With anemia, if there's also iron deficiency, then oral or IV iron is given. If there's no iron deficiency and hemoglobin levels are under 10 grams per deciliter, then subcutaneous erythropoiesis-stimulating agents are given. With hyperphosphatemia, dietary phosphorus intake is restricted, but if this doesn't work, oral non-calcium-containing phosphate binders are given. If PTH levels are above 195 picograms per milliliter, and if there's vitamin D deficiency and hypocalcemia, then treatment with oral calcitriol or alpha-calcidol is given. Renal replacement therapy is typically started with ESRD, and options include renal transplantation, hemodialysis, and peritoneal dialysis.